Black Health Matters family. We have had an amazing day. The last panel on mental health, and especially with a focus on African American men, was truthful, powerful, but heartbreaking. There's so much that needs to be done. So we thank Dr. Cartman and we thank Dr. Brotman for being here and to helping raise awareness of why we cannot stigmatize mental health in our community. We're happy that within the last year, when we did our most recent survey on African Americans and mental health, we saw that more of us reported that that is an issue. Prior to COVID and the pandemic of racism that has been uncovered, that response was not something that we saw on a regular basis. So we really are pleased that the messaging is penetrating our communities, that we can say we've got anxiety, we've got trauma, and we want help. I want to just share, we have some die-hard Black Health Matters fans on this platform today, competing for prizes on the leaderboard. Oh my goodness. It happens, it's neck and neck. You all are, it's a grudge match now. Coming in at number 3, we have Lisa Jones with 4,690 points. So she has launched quite a formidable offense. We have Verna Lennon at 5,535. She has jumped into the top 3, but the reigning champ, who has continued to increase the number of points that she has received on this platform, is Sharon Barbour with 5,860 points. So again, the top 25 who interacted and went to the sessions and chatted, went to the exhibit hall, you all are going to be able to walk away with some really great prizes. So we definitely want to thank you for your participation. Now I'd like to talk with you about lupus and lupus nephritis. This discussion is sponsored by Kezar. What's interesting about lupus, according to the Lupus Foundation of America, lupus is 2 to 3 times more prevalent among women of color. Research indicates that lupus affects 1 out of every 220 African American women. That means that we know these women. When we did some programs about 2 years ago in Harlem, we brought together a group of women who had lupus. What we found is that there was just a lot of sadness and a lot of feeling disenfranchised. One of the things that I walked away with is the thought that, you know, when a woman says, I have breast cancer, we all say, oh my goodness, how are you doing? What is your therapy? What's going on with the chemo? We have some pretty good questions to ask to show that we empathize with her. But when a woman says, I won't be able to make that function because I have lupus, often we just draw a blank stare because we don't understand the disease, how disabling that disease is, and what a challenge it is for that woman to be able to just do daily, everyday tasks. So after you finish, you know, you might ask your girlfriend out 4 or 5 times who has lupus, and once she stops coming to the functions, you might forget about her, but don't forget about her. She's not trying to ignore you. This disease is serious. It attacks your autoimmune system. So we are so happy to be able to shed a light today on lupus and what the outlook is for people and patients who have lupus. I'm pleased to introduce you all to John Fowler. John Fowler is Kezar's Life Sciences co-founder, chief executive officer, and a member of the board of directors, bringing over 20 years of executive leadership and experience to the company. Mr. Fowler has been a successful operator in organizations ranging from high-tech startups in the U.S. government to serving as the CEO of Aero Logistics from 2003 until 2008, and as CEO of Health CPA from 2009 to 2014, a provider of patient advocacy insurance navigation services. He previously worked with Idea Lab, Silicon Valley, and also as a management consultant with William Kent International, advising clients on international acquisition opportunities and market entry strategies. He began his career in Washington, D.C. as the Congressional Affairs Specialist for the U.S. Trade Representative. John received both his A.B. in International Relations and his MBA from Stanford University. So I'm going to introduce you to John Fowler, who then will introduce you to Dr. Samir Parikh. John, please take it away.
Thank you so much for that very kind and flattering introduction. It makes me feel like I've worked at a lot of jobs in my career. I'm feeling old right now, but it's an honor to be here. And I really want to thank you for that incredibly thoughtful and articulate introduction to lupus in general in the Black community. It really is very sobering how disproportionately it affects Black women in particular. And not to steal one of Dr. Parikh's data points that he'll share with you, but half of those women will go on to develop lupus nephritis as well, which is a really serious manifestation of lupus that impedes kidney function and can lead to dialysis. And you'll hear a lot about that from Dr. Parikh. So it really is my honor not only to be sponsoring this session today as the CEO of Kezar Life Sciences, but to introduce Dr. Samir Parikh. He's really a leader in the lupus space. We're honored to work with him on our clinical trials, and I'll speak to you about a little bit after his presentation. But he and his team at Ohio State have helped so many patients throughout the Midwest deal with their lupus and their lupus nephritis. And as he said, I think there's, or you'll hear from him, that I think there's some really exciting developments on the horizon in terms of new therapies that not only are from our company, but from other companies to help patients living with these diseases. So I look forward to chatting a little bit after his presentation, but without further ado, I'll let you take it away, Dr. Parikh.
Thanks, John, and thank you very much for that introduction. And I want to thank the organizers at Black Health Matters for inviting me to be here with you guys today. Especially to talk about a condition in lupus that is very important to me and the patients I care for. Just give me a second as I share my screen. That's it. And let's go to there. Okay. So the topic or the title of my talk today, and I'm going to present some data on lupus nephritis, and where we are today in 2020. So living with lupus nephritis in 2020, disparities, and talk about treatment and outcomes. These are my disclosures here. I work with a number of pharmaceutical companies, as well as have grant funding from the NIH and industry. But the objectives of this talk is to define systemic lupus erythematosus, or SLE, or lupus as we call it, and kidney disease associated with lupus, or lupus nephritis. We're going to talk about who is affected, who's at risk, and what are the outcomes. And then we'll touch on the health disparities and the impact that has on the outcomes in lupus and lupus nephritis. Finally, we'll in this brief time that we have, we'll talk about the current management of lupus nephritis and what the future holds for the care of our patients. First, let me define lupus. So systemic lupus erythematosus, or lupus, is a chronic relapsing multisystemic disorder of the connective tissue. Basically what it means is your immune system, which has a very sophisticated checks and balance, breaks down at some point. And that point where it breaks down can lead to immune proteins developing in the body, and then your own immune system starts to attack the organs of your body. In general, this is called autoimmune disease. And in lupus, this is the hallmark autoimmune disease. It's in the differential. As a clinician, someone who takes care of patients, we always think about it when we have complicated presentations for patients. But basically this disease, if you look at the very left bottom panel, can affect almost any part of your body. Maybe the most common presentation is debilitating joint pain and inflammation of the joints, as well as rash, and even erosions and hair loss that can be patchy and lead to ulcerations. In its most severe form, lupus can affect the kidney, and it can affect the heart, and it can affect the brain. When it attacks the kidney, which occurs in about 50% of cases, it causes inflammation or swelling of the very, very, very small blood vessels, so the microvessels, which end up leading to damage of the filtering membranes, or the kidney filters we call glomeruli. This is essentially lupus at its worst. Basically, immune proteins that are in circulation are depositing in the kidney, which is attracting your own immune system to lead to a very inflammatory response that can essentially take the organ out in entirety if we don't stop the injury. So on the left here, on the bottom right panel, you can see a normal, healthy kidney, and then an inflamed kidney on the right. And this is what happens in lupus. It gets swollen, it gets inflamed, and that can lead to chronic scar if we don't address it. So who gets lupus and who gets lupus nephritis? Well, in fact, women are 9 times more likely to get lupus than men. And it's not just women, it's young women. It's children, teenagers, it's women of childbearing age. And in fact, Black women are 3 times more likely to get lupus than white women. As was mentioned, 1 in 250, approximately 1 in 250 Black women in the US will be affected by lupus. So what are the risk factors associated with lupus and lupus nephritis in particular? So those who will get lupus nephritis, so I mentioned roughly about 50% of patients will get it. Well, those who are younger, and actually male sex. So if you're a male with lupus, you're more likely to get lupus nephritis. And then I put up here non-European ancestry. So if you look at the figure to the right, this is looking at the percent of patients who have diagnosed with lupus and then went on to develop lupus nephritis after the diagnosis of lupus. And in red, you can see patients who are Black patients, orange are Hispanic patients, blue is white patients. And the higher risks and significantly higher risk in those of non-European ancestry or non-white patients will go on to develop lupus nephritis. And lupus nephritis itself, and so why do we care about lupus nephritis and lupus kidney disease? I say it's something that we need to stop before it develops chronic damage. Well, it's associated with the worst outcomes in lupus. So the most complications, morbidity, and the greatest mortality. And still to this day, despite advancements in our understanding of the disease, new treatments, about 10 to 30% of patients will go on to develop end-stage kidney failure within 15 years of diagnosis. So as an example, think of a 20-year-old who's diagnosed with lupus. A 20-year-old female was healthy and then all of a sudden started to develop this autoimmune disease of no doing of her own. And 15 years later, so at the age of 35, she's gone on to develop end-stage kidney failure and require dialysis or kidney transplant. This is the challenge that's in front of us. This is what we're trying to find better treatments for, address earlier, and stave off this chronic kidney damage development so that these young patients can live longer, healthier, and feel more quote unquote normal as their peers and their friends that they're going to school with or working with. So let's look a little bit more at the disparities here in terms of the death rates or mortality when we compare according to race and age. So this is looking at Black and white women, and this is older data from 1979 to 1998, but as reported by the Center of Disease Controls or the CDC. And what you can see is that racial and ethnic minorities in general are more likely to develop lupus at a younger age and have more severe symptoms at disease onset. Additionally, mortality rates for Black patients is at least 3 times greater than white patients, as I mentioned. And this is looking at every different age group, basically. This is in the upper graphs here, or lines here. This is the rate of mortality per 10 million population. The solid line is greater than 65, and you have 45 to 65 years old, and then Black patients from 15 to 44 years old. It really doesn't matter at every age group. Black patients tend to do worse, have greater mortality than white patients. And just looking at end-stage kidney disease and lupus nephritis, this is looking at standardized incidence rates of end-stage kidney failure due to lupus nephritis. This is from the United States Renal Dialysis database from 2001 to 2006. So looking at billing records, and what you find here across all ethnicities and race, so Black, Asian, Hispanic, Native American, and white, the highest risk of developing end-stage kidney failures are in Black patients, but also every other ethnicity other than white patients are at higher risk of developing end-stage kidney failure. So this leads to the definition of healthcare disparities. And I know you guys have discussed this throughout the day, but health disparities as defined by the National Institutes of Health are the differences in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. Healthcare disparities, though, specifically refer to the differences in access to or availability of facilities and services to care for disease. So let's see, when it comes to lupus, one of the biggest questions we've had as providers is why are patients, minority or those of Black or Hispanic, Why are they at higher risk for developing lupus kidney disease or have worse outcomes? And so that took us to look at a number of factors. And I'm going to highlight a few of those here. So first, the prevalence of lupus and lupus nephritis. So this is looking at Medicaid enrollees. And they looked at Medicaid enrollees with lupus or lupus nephritis and sought to see what the prevalence was according to zip code. And what they found, and this is looking at the socioeconomic status and then adjusted adjusted according to age, sex, and race. And what they found, the unadjusted risk was highest in patients with that lived in the lowest socioeconomic status. And these findings remain true after adjusting for other risk factors, including age, race, and ethnicity, although they weren't as profound. And this is looking at lupus and then lupus nephritis. And the differences were more profound in lupus than they were actually in lupus nephritis. So then the question becomes is why are patients at lower socioeconomic status or in these areas of lower status developing lupus and lupus nephritis? Why is the prevalence higher? This is not talking about disease severity. We're talking about prevalence. And could it be due to environmental factors or toxins potentially that could be triggering these at-risk patients? So maybe they're predisposed genetically and then at risk. Or contrarily, could it be that just having lupus alone is so costly and so debilitating that it leads patients to move into lower socioeconomic status locations? So that's something that couldn't be teased out from this data, but just something to think about. So what about healthcare access and really meeting quality measures? So things that we set out to say, you know what, if you have lupus, you should have X type of treatment. And these are the things that we should be hitting. And let's look at racial and ethnic minorities and look at the risk of, or the potential of meeting these healthcare quality measures. And so we looked at both race and ethnicity here and socioeconomic status here and the figures to the right. And what you can see is unadjusted. When you don't adjust for age or poverty in this case, disease duration or healthcare utilization, you see that the risk appears to be higher in patients of, according to race, with white patients doing better than non-white patients. However, when you adjust for the different factors, so age, poverty, disease duration, healthcare utilization, and health insurance, those differences seem to subside a bit, and this becomes non-significant statistically. What about poverty? This seems to be the same deal where it's unadjusted. You can see that it seems to be, the risk seems to be considerable. But when you adjust for the other factors, the differences actually decline. So the question is here is that, yes, we understand that socioeconomic status matters. We understand that race, ethnicity matters, but there's more issues involved here, and it's more complex than that. And perhaps controlling for the type of health insurance or the type of access to care also matters equally potentially, and maybe part of the reason why patients are not getting or achieving the same health quality measures at least as those with better health insurance, for example. But what about genetics? So we talked about socioeconomic status, we talked about race and ethnicity, but does genetics play a role? And is that contributing to the risk of lupus and lupus nephritis? Well, there's still a lot to be determined here. It's ongoing areas of research. Lupus is a rare disease, and to do genetic studies, you need a large number of patients. Anyhow, there's about 30 different genes that have been identified through large genome-wide association studies that have been identified to be lupus risk genes. And what about in lupus nephritis in Black and Hispanic patients? Well, we know that clinically and pathologically, meaning when we look at the kidney tissue, they appear to have more severe disease when they present. They have more circulating immune proteins in their blood. They have more inflammation in their kidney. And clinically, the disease appears to be more severe. So more severe acute kidney failure, more severe protein in the urine, which is a hallmark of lupus kidney disease. So this suggests that sociodemographic factors alone are not to explain the higher risk, but there's multiple contributors here. And one genetic variant I want to highlight that may confer higher risk in Black versus white patients, and you may have heard about this earlier in the day's session when in the discussion about FSGS, but this is APOL1. So APOL1 is a variant, is a gene we all have. But there's variant alleles, so changes in that gene that have been identified in Black patients in particular, and there's a history to this in evolution. So in Western Africa in particular, there's a parasite called trypanosome that was pretty endemic to the area. And it appears that when you have variants to this gene, so meaning that the gene is modified a little bit, it's protective against this trypanosome parasite. But it seems to be that at least there's an association with these variant alleles and having increased risk of kidney disease, not just lupus or lupus nephritis, but also other kidney diseases like hypertensive kidney disease or HIV-associated kidney disease. And one of the questions I always asked when I was in training was, why is it that we always only see the 20-year-old African-American male on dialysis with out-of-control blood pressure? And the answer I always received that was unsatisfactory to me was that, oh, well, they just don't take their medicines. And I was like, that can't be true for all of these patients. And it just so happens that it just seems to be that it's not the hypertension maybe that's leading to the kidney failure in these patients. It's that they're genetically predisposed to developing kidney disease. And then there might be other factors that lead to the quick progression to kidney failure, but still there's more than just meets the eye and more than just what's on the surface here. So just to highlight one potential genetic variant that could be contributing to more aggressive disease we see in non-white patients. So what are the drivers of health disparities in lupus? So we touched on a lot of these here. There's fixed factors like age, sex, race, socioeconomic status, but there's also potentially modifiable factors that we can change to help improve outcomes. And that includes the healthcare system, access to care, and psychosocial issues, adherence to medicines, and follow-up. So these are things that I highlighted here. So access to quality healthcare. And what does that mean? That means having providers that are part of your care team that you can see routinely, not just one time, but you have access to, you can ask questions of. Access to medications, are they affordable? Can you get them? Are they covered? These are important issues that we tend to run into all the time on the back end of patient care that takes up a good considerable amount of our time so that we can get our patients the medicines they need. Access to necessary subspecialists, such as rheumatologists and kidney doctors and dermatologists in the setting of lupus, resources, social support. And then finally, two of the most important factors, at least in my view, is health literacy and trust. So health literacy, what does that mean? That really means when you're sitting with a patient, being able to discuss with them their disease in a manner that they can understand it and they can appreciate the disease so that they can become educated on it. Because once you have that, then the patient is empowered to look for the care that they need. And then lastly, trust. And I think that comes from developing all these other issues, but trust is a big issue. And in particular in the Black community where there's historically been a lot of distrust of with the medical community, clinical trials, et cetera. And that's for a large part valid. And a lot of it has to do with, again, having the time to develop that relationship with your patient, talking to them about their disease, and allowing them to help them understand so that you can have that relationship that is longitudinal, not just point in time. Anyway, I want to finish up quickly about the management of lupus nephritis because John's going to talk a little bit more about this. But when patients present with lupus and signs of lupus nephritis, things that they might present with are dark urine, foamy urine, decreasing urine output, swelling or weight gain, and high blood pressure. But commonly, patients present with very few symptoms. Incidentally, they're found with abnormal kidney function or protein in their urine, and they come to the kidney doctor and they really say they feel well. And it's our job to convince them, frankly, that while everything feels well, inside your kidneys are hurting. And in lupus nephritis, sometimes we see that. The kidney injury can be silent. Patients may not have overt symptoms specific to kidney disease. They're young patients, they tolerate a lot. And so the evaluation must be done periodically to look for this, especially in patients with lupus, so that we can identify it early and address it early before chronic damage develops. So how do we treat lupus nephritis? So lupus, I won't go into great detail here, but lupus nephritis is treated with broad therapies that suppress the immune system. So these therapies can be toxic, they carry a lot of side effects, but they're importantly necessary, unfortunately, at this point, to actually suppress the disease so we can control and preserve the organ. So this requires high-dose corticosteroids and medicines like chemotherapy medicines, really, to help suppress the immune system that is required intensively in the first 3 to 6 months of diagnosis, and then at least over 36 months of treatment presuming you would attain a complete kidney remission, and then there's a discussion of whether we can minimize the therapy. But because there's no cure for this disease, it's a relapsing disorder, these treatments may need to be on board over and over again, depending on how often the relapses occur. But with that, if you are able to attain a complete kidney response, that means the protein in the urine goes away, the kidney function is good. Patients tend to do well over the long term. 92% will do really well. But if you don't attain this response, you say you attain only 50% of the response we want you to attain, or don't attain any response at 12 months, then the outcomes can be fairly dismal. You can see 87% go on to develop dialysis if they don't respond to treatment. So how do we do with our current therapies? Well, frankly, not that great. So less than 50% of patients will achieve any remission after 12 months of treatment. And less than 25% of patients will achieve a complete kidney response after 12 months of treatment. And since chronic damage accumulates quickly, and with each flare, more and more damage occurs, it's not that just we need to control this flare that is present. We need to prevent future flares. The need for new and more effective therapies is crucial and critical. And because our ultimate goal in treating lupus nephritis is to preserve long-term kidney health and prevent kidney failure. So that brings me to my last couple slides and looking to the future and personalization of medicine in lupus nephritis. And I'm happy to report, probably for the first time ever, there's been a lot of positive news in the field of lupus treatment. Many clinical trials that have come through and actually have been positive in phase 2 and phase 3 design, where a large number of patients were treated. So this gives us hope, especially as providers who care for patients with lupus, that there's new therapies that are on the way that are going to help us improve our outcomes for our young patients so that they don't develop this significant chronic kidney damage or worse related to their lupus. And with that, I'm going to conclude just with the following few statements: that lupus nephritis is a severe complication of lupus. Education, awareness, and early recognition are critical, but there's barriers to exist that prevent early disease recognition and treatment that we need to get over. Health disparities in lupus and lupus nephritis are considerable and impact outcomes. Racial ethnic minorities have poorer outcomes, but there are both non-modifiable and modifiable factors that contribute to these outcomes. And we have to address these modifiable factors to improve outcomes for our patients, our individuals with lupus and lupus nephritis. Conventional treatments are effective, but there is considerable room for improvement. And new treatments are needed to improve outcomes and better preserve long-term kidney health. And with that, I'll stop and I'll turn it over to John so that he can talk about a very exciting and potentially new therapy for the management of lupus and lupus nephritis. Thank you.
Wonderful. Thank you so much, Samir. That was an awesome presentation, and I'm going to share my screen now and go into presentation mode here, and hopefully everyone will be able to see this okay. Great. So I'll just wrap things up today and build upon the great information that Dr. Parikh shared with you all about this really terrible disease. I'm just so honored and feel really fortunate to be a part of this company. And I'll tell you a little bit about the company. It's been a 5-year journey at Kezar so far, where I was very fortunate to be a co-founder of the company. I actually founded the company with my best friend from high school, Chris Kirk. You can see some of the employees of Kezar here. This is sadly the only way I get to see most of my staff these days in the age of the COVID-19 pandemic. But I am deeply humbled by their passion and commitment to working on therapies for some of the most severe diseases. We're first and foremost working on lupus and lupus nephritis. That's where our first clinical trial started, but we also have other trials with KZR-616, which is our drug candidate, as well as some new drugs in the pipeline to treat cancer. So I think lupus and lupus nephritis are a very profound unmet need and place to start, but we have big ambitions to do big things with some pretty fundamental parts of human biology. I know that within the summit this weekend and the last days or two, you've learned about clinical trials, and I will not belabor this slide very much, because I'm pretty sure that most of you have been able to learn about how clinical trials work. It's really the lifeblood of my company to be able to test these experimental drugs with physicians like Dr. Parikh and his colleagues at Ohio State and many other academic medical centers around the United States and beyond to really answer key questions around whether or not new therapies are both safe and well tolerated, but also work in a wide variety of patients. Clinical trials take a long time to complete. It's typically about 10 years from start to finish to getting an approved drug. Where we are with our KZR-616 studies in lupus and lupus nephritis right now is in the phase 2 portion. We've actually given our therapy to over 100 healthy volunteers. And based on that positive safety and tolerability profile that we saw, we've been able to move into a phase 2 study, which is sort of this middle ground of the clinical trial process. And that's what Dr. Parikh's center is working with us on, and many other centers. And at the end of our presentation today, I'll have a website and email addresses in case you want to learn more, if you have friends or family that would be interested in attempting a new experimental therapy like ours. And I'll talk to you about why we're excited about it. It goes obviously well into phase 3 and beyond. And even after you get FDA approval, you want to continue to test the drug and confirm that it's being used in the broadest and best way possible. And we look forward to getting our drug 616 all the way down this, this journey and into the hands of as many patients worldwide as possible. So we call our clinical study treating patients with lupus nephritis here in this phase 2 study, the mission study. We're definitely on a mission to bring a totally new therapy to market. As a San Francisco-based company, we've named our clinical trials after neighborhoods in San Francisco. So that's the Mission District. You can see a clock tower at a famous church, and then one of the California missions. Then we also have Presidio study treating patients with dermatomyositis and polymyositis, which is a slightly less common autoimmune disease like lupus nephritis, but also very severe and shares the sad reality of having very few treatment options for patients today. And you can see we're getting close to getting into clinical trials with our first oncology drug with KZR-261. And sadly, won't talk too much about that today, but there's a lot more than enough to talk about this KZR-616. So I don't think I need to talk too much about lupus nephritis. You've got a powerful and sobering list of statistics from Dr. Parikh around how serious this disease is. And by our best estimates, approximately 150,000 patients in the United States alone suffer from this. And even though there's some good drugs now getting late into the pipeline and showing good phase 3 results, there's currently no new approved treatments in either Europe or US. And that speaks to unmet need. And when you think about both dermatomyositis, polymyositis, and lupus nephritis, no one wants to take steroids for a long time, and no one wants to take chemo for any period of time. And so we're really excited by the data that we've generated so far that leads us to believe that we can sort of spare some of the steroid-related side effects and immunosuppression that happens with many of the drugs that patients today are compelled to take to get their flares and their overall lupus nephritis under control. That is our baby. That's KZR-616. You can see it's a molecule that's a combination of carbon atoms and oxygen atoms and hydrogen atoms, nitrogen atoms. It's very cool science. And it's important when you're developing a drug to have a drug that's sort of well behaved. You want to know that it doesn't accumulate in your body. You want to know that you can take it when you're taking other drugs and not have kind of drug-drug interaction side effects. Right now, in our clinical trials, people receive their weekly injections of KZR-616 in their doctor's office, but we also have home health nursing services, and we'll soon have the ability to do self-administration at home via a small injection, and right now in your torso or arm or leg, again, once a week. And again, based on the 100+ patients with lupus and healthy volunteers that have received the drug, we think that the overall tolerability profile and safety profile means that this is a drug that patients can take over as long a term as they need to keep their lupus nephritis and lupus under control, which is really, really important and meaningful to us. So I will resist the natural urge I have as the CEO of KZR to go into a deep science discussion. But these immunoproteasomes, most people have not heard of them, but they're really critical, almost master regulators of immune cell function. Our immune systems, like Dr. Parikh mentioned, are incredibly finely tuned and powerful machines that keep us all alive. They're also multifaceted. There's many different types of immune cells like B cells and T cells and macrophages and dendritic cells. be that as it may, each of them express this special immunoproteasome. And when these immune cells go haywire and attack normal healthy tissue, we believe that when KZR-616 is applied, it kind of calms down that overactive immune response and restores a normal immune surveillance. And we've seen very, very thoroughly, and my co-founder Chris has done well over a decade's worth of research on the biology of the immunoproteasome, that this target, the immunoproteasome, is upregulated. It means there's much more of it when you have autoimmune disease going on. And when 616 is applied, we can instill that more harmonious state of normal immune regulation in the body. That's really, really important. And patients who are suffering and living with autoimmune disease desperately need that harmony to be restored. So just one more. Thanks for indulging my science here. But there's images of 3 different types of immune cells. There are a macrophage and a T cell and a B cell. And on the right side, we've attempted to illustrate the types of inflammatory proteins that Dr. Parikh spoke about that drive inflammation, that drive autoimmune disease. One of those there, you see TNF alpha right at the top. That alone, that one protein is the target of one of the most best-selling drug in the United States for rheumatoid arthritis. We knock down not only that inflammatory protein, but many, many others that you can see there, and also reduce autoantibody levels and B cells. So what makes this treatment unique in our view is its broad activity, its ability to really act across the entire immune system, that in lupus and lupus nephritis patients in particular is going haywire broadly, not narrowly. And there's our handsome little molecule holding the baton and conducting the orchestra back into harmony and out of control autoimmune response. And that's what we want to achieve with KZR-616. And we're extremely excited about the mission study in lupus nephritis. We're really honored to be working with Dr. Parikh and his colleagues and team in Ohio State, and again, in many other locations in the United States. So as a final closing note, I'll just say that it's super important to us, given some of the healthcare disparities that exist in this many ways broken U.S. healthcare system that we all live in, that we make it as easy as possible for patients of every socioeconomic class and race to participate in this study. And that includes, for us, having home health nursing services available to come to your home. If someone is traveling to clinic, we can work with the clinic and the patients participating to cover travel expenses, even offer stipends. So it's our mission in every sense of the word to get this clinical trial filled with patients who need these therapies, and then we'll be working our hardest and best with people like Dr. Parikh to get that drug to people for as long as they need it, and measure the outcomes so that we can eventually translate this research into a commercial product available very, very broadly for the widest array of patients possible. So again, it's really an honor to sponsor today's session, an honor to share the virtual stage with Dr. Parikh, again, who is a humble guy, but he's really helped a lot of patients in very profound ways. And very excited as well to hear your questions and respond and be helpful in any way that we can after this session is completed. So again, thank you for the opportunity to talk to you today. I will stop my screen share since I don't think you need to look at this slide anymore, but I don't know if the operator wants to take back over control of the session. I was told we had until 4:45, so I'm proud of myself for coming in just under the wire and not doing my usual talk too long and go over my allotted time.
I do the same thing, so I'm happy about that as well. I do see there's about 6 questions in the Q&A, so I don't know if we can just start answering them.
Yeah, so if you can please address these.
Okay, so I guess the first, sorry, I'm just pull this up. So the first question is, what precautions should a person with discoid lupus erythematosus take to prevent it from getting worse? So I can answer that at least to some extent. I'm not a dermatologist, but discoid lupus, for those who don't know, is basically skin-limited lupus. It can be quite debilitating, cause quite a lot of scarring in the skin. And the main precaution that you can take to help prevent it from getting worse is really the same precaution that we advise for all of our patients with lupus. The sun, unfortunately, and ultraviolet light is quite a trigger for lupus flares. So limiting sun exposure, covering up, and wearing sunscreen are some of the major precautions that you can take to help prevent skin flares and photosensitivity that can occur with lupus as well as discoid lupus. So that would be the main precaution. I think the other one would be frequent follow-up and a good relationship with your dermatologist or skin doctor and rheumatologist to make sure that the discoid lupus isn't converting into something more systemic as well with time. There are topical therapies as well as immunomodulatory therapies that are effective. And one of the hallmark therapies for all of lupus, and that is very effective, it's effective in helping lupus patients who are pregnant even, is hydroxychloroquine. So that's a drug that's gotten a lot of pub for the wrong reasons, but it's gotten a lot of pub. It's a drug that's highly effective in treating lupus. And unfortunately, it's a drug that sometimes is often on back order because not a lot of it's produced. So it has been a struggle for the last several months to get our patients with lupus this medicine, but it's not a suppressive medicine, it's a modulatory medicine, and all patients with lupus, unless they have a side effect or allergy to it, should be on it. Hopefully that answers your question. Certainly happy to answer follow-up. The next question is, do patients with systemic lupus have increased risk for developing COVID? I think the short answer is yes. If you're immunosuppressed, so if your immune system is suppressed, you're at risk for developing any infection, basically, because when your immune system is suppressed, that means your body's ability to fight infection is suppressed. And so certainly patients with lupus do have a higher risk of a potentially higher risk of developing COVID. That being said, there hasn't been large studies looking at this specific question, but just knowing our history with other viruses, including the flu and then bacterial infections, certainly the risk is there. Can a person with a sickle cell anemia develop lupus? I think the answer there is also yes, they can. I have not seen it very often, but it can happen. And you can have both diseases. They are very different and independent. One is clearly a genetic disorder. The other one has a genetic component with other factors involved. The next question I'm going to defer to John. This is how have you been able to continue your clinical trials during COVID, as most trials require on-site visits?
Yeah, we have kept the trial open for screening and enrollment, but we are aware that at least half, if not more than half, of our investigator and trial site partners have either slowed down or stopped in ways both minor to moderate to major over the last 6 months. Our sense is from talking to the sites is that in the last 4 weeks, they're kind of reopening and seeing a higher flow of patients coming into their lupus clinics and being willing to get screened for clinical trials. But certainly we did see a slowdown for the first several months after the pandemic really kicked into gear. But it's open for enrollment and screening, and it really doesn't feel like the right answer to shut it down completely for the duration of the pandemic, because protocols can be followed to make it safe for patients to participate.
If I can just add, so at Ohio State, we do a lot of clinical trials. Obviously, there was basically an essential stop to clinical trials in March and April. But I would say since May and June, we've been essentially back up and running with almost all things, clinical trial and otherwise. And I think basically what I can say about that is that if the proper precautions are taken, and we do that, it has allowed us to continue with our clinical trials, and we're ramping up now. I will say that it also has highlighted a few things with clinical trials going forward that may be the wave of the future, including home visits, as John has mentioned, and home health nursing and that type of thing, so that patients who live more remotely can participate in clinical trials a little bit easier than it is at present. Okay, so I think this is a comment more than anything else. Super excited about clinical trials, as I have many friends who have been diagnosed with lupus. We share your excitement about what's happened recently in the last year with the late phase trials and what's to come, frankly. I think the ultimate goal for us is we understand that lupus is heterogeneous and not one therapy is going to fit all. So having basically a toolkit for providers so that we can match the right therapy for the right patient is our hope for the future. And hopefully we're moving towards that goal. The next question is, I was recently told by my rheumatologist that my lupus is now in remission since my symptoms and the last few labs haven't indicated inflammation. Is that such a thing? Absolutely. So, you know, as much as I presented some sober statistics, lupus does absolutely you can attain a remission. In remission meaning that your lab suggests your disease is under control, and clinically, and that's the most important, you feel good and you are not expressing symptoms that suggest lupus is active. And there's a lot of different metrics that providers will use surveys and things like that to gauge lupus activity. And so if your provider suggests that your lupus is remission and you feel the same, then that's a good thing. Now, the big thing going forward is keeping you in remission and how to do that, because this is a relapsing condition. It's not something that is curable at this point in time. Is it ever hereditary or passed on through generations? So lupus is a condition that has a genetic predisposition to it. Oftentimes we do disease histories or histories of family histories, and we can find family members. And it might be aunts or uncles or cousins that have an autoimmune disease or lupus in their history. And certainly if you have one autoimmune disease in the family history, that may be that you may be at risk for an autoimmune disease as well in your family, but there's not a direct generation to generation pass on of lupus, although we have seen it in some families. What about Hashimoto's disease, immune deficiency? So Hashimoto's disease is a thyroid disease. It's basically caused low thyroid function. And certainly it's a hormonal disease more than an immune disease, but it is autoimmune. So it's to suggest that the immune system is producing proteins or antibodies that attack your thyroid. And the treatment for that, frankly, is thyroid replacement therapy. Is there immune deficiency? There is maybe some mild immune deficiency that goes with it, but replacement of the thyroid with the hormone should effectively treat that and treat the disease itself. Okay, let's see. After suffering with pain for years, I was told 5 years ago my numbers were low for lupus. No follow-up has been done. What do I need to do? So certainly I'm happy to discuss this offline with you as well. It's really important to have a regular provider that you have a relationship with that you can trust to help care for your lupus. And I know in some places, in some regions, it's hard to find those folks, starting with your primary care provider. And then hopefully, in most cases with lupus, a rheumatologist is important. Pain is real in lupus. Joint pain can be both acute and chronic. So after you had a lot of acute inflammation, that can lead to chronic joint pain and arthritis. And numbers being low, that can mean a lot of things. It depends on what numbers we're talking about. But if it's reflective of lupus labs, low numbers often mean active disease. So absolutely, I would suggest follow up. And certainly if you're, if you want, if we can discuss offline and you can let me know what region of the country you're in, I might be able to plug you in with some people I know. Okay, this is John. I think you can take this one. In follow up, have you considered adding remote patient monitoring?
The quick answer is absolutely yes. Yeah, we've done everything and we're continuing to put in place services to make it as light touch as possible for patients participating in our studies so that they don't have to come into the clinic on a weekly or even bi-weekly basis. I mean, I don't think we'll ever get, and I think you'll agree, Dr. Parikh, that we can't get completely away from ever coming to see the doctors. And there's a certain cadence of just where the doctor wants to see you and confirm that how you're doing. But I think it can be very patient friendly and convenient going forward.
That's great. The next question is, my sister has lupus and I have sarcoidosis. Are you aware of any connections genetically? Great question. I wish I could tell you I know absolutely there is or is not a genetic link. As I kind of mentioned in one of the previous questions, is if you have one autoimmune disease, and sarcoidosis is certainly an autoimmune disease, in the family, a different family member can have a different autoimmune disease. And in fact, I have family members that have sarcoidosis and lupus as well. So there may be some connection there. There may be some genetic link. At this point, we don't know enough to confirm or deny that. But we do know that there's predisposition for autoimmune disease if it's running in the family. I wish I could give you a better answer, but we still have so much more to learn about genetics in autoimmune disease. And I think that's still going to be several years away before we truly understand this. And maybe the last question for the session. I have gastrointestinal issues often and take some medications to control IBS symptoms, nausea, vomiting. I have often wondered, was it in any relation to my lupus? Never heard of lupus attacking the digestive system though. So the short answer of whether lupus can attack your digestive system, it absolutely can. And when it does, it's usually really severe. There's something called lupus enteritis, for example. And basically what that means is your entire small bowel is inflamed because of lupus. Now, those symptoms are pretty severe. They cause malnourishment. There's a very specific way to diagnose it. The presentation's very acute and very obvious. Protein in the blood goes down, abdomen gets distended, you can have blood in your stool, things like that. Certainly, if you're on medications for your lupus, sometimes the medications that you're on themselves can cause nausea, vomiting, GI distress. Mycophenolate mofetil, for example, comes to mind, or Cellcept, as it's commonly called. And prednisone can cause a lot of problems. So steroids can cause a lot of problems with the GI tract, particularly ulcers, as well, and acid reflux. So those are things to consider. Otherwise, I think from what you're stating, I think it's important that we don't just, as broad as the differential can be when it comes to lupus, and it can affect every organ, we want to make sure that we're doing a thorough evaluation of your GI symptoms and not just attributing it to lupus, for example, although it could be, but certainly you want to make sure you have the appropriate GI evaluation to make sure we're not missing something else. Okay, I think there's one other last question. Are there any new medications beside Plaquenil? So I showed a table in the talk, and I kind of showed it quickly, so I'm sorry, but there are a lot of immunosuppressive medicines. So let me back up. So Plaquenil is a medicine that is tried and true, does not suppress the immune system, but is very good for lupus. It's immunomodulatory, we call it. But there are new medicines in the pipeline that are coming that have not yet been approved. So to date, there are no new FDA-approved therapies for lupus. And John and his team and others are actively investigating this area to try to identify new therapies for the management of lupus and lupus nephritis. To this point, the two major therapies for lupus and lupus nephritis, and this is somewhat unsatisfying, are hydroxychloroquine or Plaquenil and steroids. And the other therapies that we use, like azathioprine, mycophenolate, methotrexate, cyclophosphamide, those are all relatively strong immunosuppressants that you want to minimize. You only want to use them when you absolutely have to, and when you can get off them, you want to. Because of course, we don't want to we want to balance the benefits of these therapies with the risks associated with these therapies, and in particular, the risks with infection. Okay. I think that those are all the questions that I can see.
Yes, thank you so much, Dr. Samir and John. And I hope this was an insightful session. So thank you so much, all the attendees, for joining the session, and see you in the closing session now. Thank you so much once again.
Great. Thank you.
Thank you very much, everybody. Have a good day.
You too. Have a good day.